Today on Derm School, we will be looking at two common parasitic infestations, namely scabies and lice. So we're looking at scabies and head lice. What is scabies? Scabies is a superficial epidermal infestation by the mite Sarcoptes scabies var hominis. Transmission is through skin-to-skin contact and fomites. The following are the risk factors for scabies: crowded conditions, poor hygiene, poverty, malnutrition, homelessness, as well as immunodeficiency. Symptoms include pruritus, which is intense and widespread, usually sparing the head and neck, and pruritus may be absent in hyperinfestation. In terms of the rash, presentations can range from no rash to erythroderma. Commonly, they can have eczematous dermatitis, especially in patients with atopic dermatitis, and tenderness can result from secondary bacterial infection. Cutaneous findings: the lesions are often seen at the sites of mite infestation. You can also get cutaneous manifestations of hypersensitivity to the mites, lesions secondary to chronic rubbing and scratching, secondary infection, hyperinfestation, and variants in special hosts such as atopic dermatitis, nodular scabies, infants or small children, and the elderly. The most typical skin finding are intraepidermal burrows. Now, burrows are skin-colored ridges measuring 0.5 to 1 centimeter in length, but can go up to 10 centimeters. They are usually linear or serpiginous, and you can see a minute vesicle or papule at the end of the tunnel. In general, one infesting female mite causes one burrow. Distribution is usually in areas with few or no hair follicles, such as the digital webs, wrists, shaft of the penis, elbows, feet, buttocks, and axilla. In infants, it can also affect the head and neck. This is a picture of an intraepidermal burrow. Nodules measure from 5 to 20 millimeters in diameter, and the color can range from red, pink, tan, or brown. It is usually smooth, and you may see a burrow on the surface of the early lesion. This usually resolves with post-inflammatory hyperpigmentation. Distribution of scabitic nodules are on the scrotum, penis, axilla, waist, buttocks, and areola. An important condition to note is scabies with hyperinfestation, also known as Norwegian scabies, and this may begin as ordinary scabies. It becomes hyperkeratotic and crusted with warty dermatosis of the hands or feet with nail-bed hyperkeratosis. The patient develops an erythematous scaling eruption on the face, neck, scalp, and trunk. There's usually a foul odor, and it can be both generalized or localized. So this is a picture of a patient with Norwegian scabies. Other clinical findings in scabies include it or autosensitization, in which patients have small urticarial edematous papules, usually on the anterior trunk, thigh, buttocks, and forearms. Secondary changes range from excoriations, lichen simplex chronicus, prurigo nodularis, post-inflammatory hyper and hypopigmentation, bullous scabies, and secondary infection with Staph aureus. Diagnosis is usually clinical, but you can also use microscopy or ink tests. In microscopy, a drop of mineral oil is placed over the burrow and scraped with a curette or number 15 blade, and this is placed on the slide. You can appreciate the presence of mites, eggs, and scibella, which are fecal pellets. At ink test, you rub around suspicious bumps with a marker, wipe away the ink with alcohol, and you can see a dark, irregular line where the ink remains with a tiny dot at the end, which is the mite. In terms of management, it depends on the age. From newborn to 2 months old, use clotametone. For children aged 2 months to 2 years, first line is permethrin 5%. Second line, clotamethone, 6% sulfur in calamine. For children 2 to 12 years old, first line is permethrin 5%, second line, emulsion benzoyl benzoate or EBB 12.5%, 1% lindane or clotamethone. For adults, first line is permethrin 5%, second line EBB 25%, lindane or clotamethone. In pregnancy, you can use permethrin 5% or 6% sulfur in calamine, and in crusted scabies, the treatment is with oral ivermectin. How do you use permethrin 5% cream or lotion? Apply this at bedtime after the bath to the entire body from the neck downwards, including the genitals, the body folds, digital webs. Wash off after 8 to 12 hours and repeat after a week. In general, all close contacts need to be treated at the same time. For EBB or emulsion benzoyl benzoate, apply and wash off after 24 hours and repeat the application for 2 to 3 days. Do not use in children below 2 years or in a patient of any age with excoriated or infected skin. EBB causes irritant dermatitis, scrotal irritation, stinging, and conjunctival irritation when the eye is touched. It can cause neurotoxicity if used in raw and eczematized skin. Close contacts should be treated concurrently even if they do not have symptoms. Decontaminate all linens, towels, and clothing used in the previous 4 days by hot water washing and heated drying. Items that cannot be washed in hot water should be dry cleaned or sealed in a plastic bag for at least 5 days. Next, we move on to head lice. Head lice is also known as pediculosis capitis, which is an infestation of the scalp by the head louse, Pediculus humanus capitis. The louse feeds on scalp and neck and deposits its eggs on the hair. Transmission is through head-to-head contact as well as the use of shared hats, caps, brushes, combs, theatre seats, and pillows. Symptoms: patients have pruritus on the back and sides of the scalp. There's often scratching and secondary infection, and they may have occipital and or cervical lymphadenopathy. So in terms of the infestation for the head lice, you can often view it by eye or using hand lens or dermatoscope. Nits are oval grayish-white egg capsules 1 millimeter long, cemented to hairs, and can range from few to thousands of nits. Sites are on the scalp, especially on the occipital and post-auricular regions, rarely on the beard and other hair-bearing areas. In terms of skin lesions, they can have bite reactions, eczema, excoriation, lichen simplex chronicus, secondary infection with Staphylococcus aureus, and posterior occipital lymphadenopathy. This is a picture of nits and surrounding dermatitis. Treatment of head lice is with topical permethrin, or malathion, pyrethrin, ivermectin, and spinosad. For oral, you can use ivermectin, bevamisol, and albendazole. So that's all, and thank you very much for coming, and see you again in the next installment of Derm School.